Namaste. This educational surgical video demonstrates complete excision of vestibular schwannoma with preservation of facial nerve function and preservation of Aica loop which was embedded in the tumor capsule. So this video aims to share the valuable insights and techniques promoting excellence in neurosurgical practice. Facial nerve preservation and hearing preservation have been achieved by significant advances in the skull-based microsurgical techniques and also by using intraoperative neuromonitoring, where even we have saved the 8th cranial few of the cases. As we all are aware, one of the most significant challenge in vestibular schwannoma surgery is preserving the delicate, stretched, fragile facial nerve which is adherent to the tumor capsule, particularly towards the end of the procedure when we fatigue, get frustrated, and we have a decreased concentration, and that is the most challenge that we all face. I firmly believe and practice that primary objective of the surgery is not just tumor removal but rather the preservation of facial nerve. So this surgery, I believe it is to the facial nerve rather than to the tumor. After all, a smile is a curve that sets everything straight. So by prioritizing facial nerve preservation, we can significantly enhance our patient's quality of life and restore the smile. In this MRI scan of a young male, you can see there is a large CP angle tumor in the left CP angle system with obstructive hydrocephalus. The brainstem and even the cerebellum are compressed by the tumor, and in 3D you can see the cranial nerves, the vertebral arteries, and these are the vertebral arteries, and they are forming the basal artery here, and the Aica loop is embedded in the tumor capsule. You can see the intraoperative meatus there, the nerves displaced, and this is important to study the cranial nerve and vascular anatomy in relation to tumor in all the cases of vestibular schwannoma. This is a surgical strategy. In all the cases, we use retrosigmoid approach, and we place the patient in lateral park bench position, and this is how position the patient. You can see the head is in elevation, lateral flexion and anteroflexion, so that the mastoid is at the highest level, and this is a lazy S incision that we take, and we are particular to place the hand in a comfortable position over the headrest, and this is a lazy S incision that we open. It is mainly to preserve to avoid the damage to the vertebral artery in the lower end. So we make it lazy S incision, and I'm harvesting the periclean graft. So I use the graft in all the cases, and this is the position that we take during the surgery. And it's quite important because you need to have a hand rested very well, and iliac retract has to be in the proper position. Then once that is done, you have exposed the suboccipital muscles, and you can see here that we are exposing, that is the mastoid part, and we are going down, that is the suboccipital part. And while cutting these muscles, you have to be sure that you are away from the vertebral artery, and you should avoid damage to the vertebral artery in these cases. And even the occipital artery, once you cut, it has to be properly coagulated, otherwise it can be cause for EDH in postoperative cases. So that is the suboccipital muscles that have been dissected away, and that is the mastoid. You can see that's a mastoid groove there, and this is the suboccipital bone that we exposed in the CP angle, and that is the asterion, and that is where we mark the first burr hole, that is at the root of the mastoid. That is exactly where we mark. So that exposes the synovial angle, that is the angle between the sigmoid sinus and the transverse sinus. So you can see here beautifully in this thing, there is a synovial angle. You can see the sigmoid sinus and the transverse sinus both here. Then using drill dissector, we dissect the dura from the bone, and we do a craniotomy in all our cases, and we replace the bone back, because this reduces significant amount of CSF leak and even pseudomeningeal formation. But you have to be sure that you are not damaging the sinus in this case. So for that reason, you have to dissect it properly, the dura, and this is what we do. You can see that the whole bone is taken out, and in this case there is some amount of the bone over the sigmoid sinus, and this is a part of the bone that I am taking near to the foramen magnum, so that I release the CSF in the cisterna magna. So this is the exposure that we get using this retrosigmoid approach, and once that is done, so you can see that I am drilling the bone over the mastoid bone mainly, to expose the transverse sinus, and these are the emissary veins which are commonly expected. There is bleeding here. I coagulate and I control the bleeding, and you can see that we are drilling, and that is the large mastoid ear cell you can see here, and we have to meticulously close all these mastoid ear cells to prevent postoperative CSF otorrhea and even paradoxical rhinorrhea. You have to find for all the ear cells open, and you have to practice something called as wax in, wax out. We wax when going into the dura, and we wax it again when we are closing the dura. So with this, you can see that the transverse sinus and the sigmoid sinus is completely exposed. All the ear cells are packed. The brain appears full under the dura, and now we have to open the dura, and since it is full, and it is very important to have a comfortable position. I told you have to have a hand rest and properly apply the light retractor, and microscope has to be in the proper position, and this is how we open the dura in a Y-shape manner. So the upper leaf of the dura is lifted over the transverse sinus, and this goes down to the lower end, and this is the dural opening at the sinoidal angle. So the upper leaflet goes, this leaflet goes over the sigmoid sinus, and this leaflet goes over the transverse sinus. And once that is done, you turn your microscope down, and this is the very important part of the procedure, because we are releasing the CSF in the cisterna magna. You can see in picture that is the CSF we are releasing there, and it is coming under very high pressure. And once this is done, the whole surgery becomes very comfortable because the brain becomes lax. You should be very cautious not to injure the pica or a lower nerves in this location. And you can see the lax brain now, and then we fix the dura to the surrounding structures so that it is a widely exposed from all the sides, mainly the lateral and superior part, and you can see the lax cerebellum here. So much of space you got just by releasing the CSF from the cisterna magna. So once that is done, using PAT, we have to protect the underlying cerebellum, and we can expose the CP angle here, that is a tentorium, and look for the petrosal veins and try to preserve it till the procedure. There is some part of cystic part of the tumor there, and that is a whole tumor that is exposed. So we use a minimal cerebellar retraction to expose this tumor here. You can see the blood vessels over the tumor. Then using neuromonitoring, I am using neuromonitoring now, and I am mapping the surface of the tumor, so to confirm that there is no cranial nerve, and that is a lower cranial nerves we are seeing now. So they are the lower cranial nerves. They are coming in a view, and there is a good plane. That is what I came to know now using this neuromonitoring. And then I protect these lower cranial nerves using a PAT till the end of the procedure, because even inadvertently will not enter the area. So once I am sure that there are no cranial nerves over the surface of the tumor that have exposed in the CP angle, then gradually using an insulin needle, I dissect the arachnoid layer and even the perineurium. So once that is done, and you keep that layer so that it will help you to dissect the tumor capsule from the medial part, that is mainly the cerebral peduncle and the brainstem. So you put the PAT in between the tumor capsule and the micromembrane so that you will get a good plane. So once you are sure of everything, then you coagulate the surface of the tumor, and then gradually you can go for internal debulking. So this has to be very meticulously, and you have to see that you are not passing the current to the lower cranial nerves. So bipolar has to be in the minimal settings, and inadvertent use has to be avoided. So on that, using a knife, I am just making an opening here and taking out the tumor and starting my debulking. The tumor is bleeding, and tumor continues to bleed till you remove it completely. So you avoid using continuous coagulation in these cases, because that might pass on to the vessel and the nerves around. And then we go ahead and decompress the internal part of the tumor using CUSA. So irrespective of bleeding, there won't be much large bleeders here, but as early as you decompress the whole tumor inside and decore it, the bleeding won't stop. And so once that is done, we decompress the tumor from all the angles. You have to change your views, apply the retractor. This is the medial part of the tumor that I am taking out. So I am aware that there is an Aica embedded in the tumor capsule, mainly in the lower part, the ventral part, and the medial part. So this is how I am shifting my retraction initially it was in the mid part, now it is in the upper part under the tentorium, and I'm decompressing the tumor here, the medial and the superior part of the tumor. So you go on decompressing it. Be aware that you are not crossing the arachnoid and damaging the structures beyond the tumor capsule. So that is where you can see this is the superior part of the tumor under the tentorium, and this is the inferior part of the tumor. I keep the patty so that they form a pressure and stop the bleeding. So using CUSA, I am taking out the lower part of the tumor now near the lower cranials. So the cranials are protected and dissected away using a patty that I have kept there, and then gradually we decompress. So here we encounter the Aica. So that is what is important, and you can see here I have taken out the patty, and they are the local nerves. They are well away, and there is a good plane between the tumor capsule and these are the local nerves. They are well away from the capsule and they are preserved. They are going into the foramina there. So this is a lateral part near the interlocustic meatus. So this is where we continue decompressing this part of the tumor using CUSA, and most of the bleedings we encounter mainly is near the interlocustic meatus, because this is from where the tumor comes out along with its blood supply. So this is a tumor capsule in the lower part, and this is a tumor capsule in the medial part, and you can see the Aica loop under my cautery there. So this has to be meticulously dissected. Aica is not common to see to be embedded. This is a first case wherein I had out of 150 plus cases that we did, and this is Aica. You can see it is quite large and embedded complete throughout. You can see at the end of the procedure that how badly it was completely into the tumor capsule. From its origin from the basilar artery till it supplies the cerebellum, brainstem and the cerebellum. So this is how, using as a rule near any of the vascular structures, we use a sharp dissection rather than blunt dissection. So this is the medial and the upper part under the tentorium, and this is the upper part of the tumor, and we are expected to see a fourth cranium here. So that is the fourth cranium now. We see thin structure. I have it is written there. This is fourth cranium now, and I am shifting back to the medial part where I am important in this particular case to preserve the large Aica which is embedded in the tumor capsule. So this particular case is quite important because not only the preserving the facial nerve, but preserving even the Aica is quite important, because Aica supplies all these nuclei, and if you preserve the facial nerve and even the vestibular nerve, and if you end up damaging this Aica, there will be an infarct resulting in neurodeficits, even though we would have saved the facial nerve. So it is quite important to preserve the Aica in this particular case where the tumor is embedded in the tumor capsule. So using a sharp dissection, I am separating the tumor capsule from the Aica. So we have to use a sharp dissection. Bluntly pulling and dissecting it bluntly might damage the vessel, and it is difficult to repair these small vessels in this location in this mindset of removing a tumor here. So this upper part, you can see that the petrosal vein is embedded in the tumor capsule, and even we save the petrosal vein in this particular case also. There are the tiny stretched facial local nerves there, and I am trying to find a space here. You can see, so that is the tumor capsule, and that is a part of the tumor, so that I maximum debulk this tumor so that the pressure over the local nerve decreases, and inward damage or handling of them decreases, because the tumor capsule becomes decompressed, and there is a good arachnoid plane. I am separating it, the tumor capsule, the arachnoid plane, and so this is these are all the rootlets of the lower cranials there, and that is the Aica. So we have to avoid a sharp dissection blindly when we have not seen anything. So if I have done a sharp dissection here, I would have damaged the Aica, and you can see these are the rootlets, the thin stretched rootlets of the lower cranials under the tumor capsule here, and fortunately in this case there was a better plane. So I am protecting the local nerves using a patty. You can see under my suction tube there is a patty. So I am with one hand, see, these are the local nerves in the foramina. So there are all the rootlets of local nerves. So this is where you can see there is a Aica coming in a loop, and there is a vertebral artery view. So this is a capsule there. These are the local nerves. So and once I'm sure that all the local nerves are separated, I just coagulate the capsule in this location, and this is the location for the vestibulocochlear nerve that is encountered in all the cases, and probably in this case we are not able to see and I could not preserve, but in most of the cases we try to see the nerve and separate and preserve at this location. And underneath you can see that is the vertebral artery. So that is the vertebral artery, and that is the Aica. If I would have extended cutting this capsule deep underneath, I would have damaged the Aica which was supposed to preserve. So once I know, then I shift from that area and continue to debulk the tumor in different locations. So this is a last medial part of the tumor that is being decompressed. So that is the upper pole of the tumor. So you go on debulking the tumor so that the thin capsule is left behind, and this is a medial part of the tumor. You can see that I have applied the retractor here, which is minimal because I have drilled the CSF, and so I am shifting my retractor at every level because there is a lot of the tumor which is buried under the cerebellum. So we cannot full the tumor capsule, and this is the tumor that we are taking out. So using neuromonitoring, I am mapping for the facial nerve here actually. So this is arachnoid being dissected away from the tumor capsule, and I am preparing a plane. I am gripping the tumor capsule, and I have a arachnoid under my patty. So I am creating a plane and dissecting the structures along with the arachnoid and preserving the structures which are beyond the arachnoid. So that is the upper part of the tumor there. That is the fourth now. Supracerebral artery will be there in the same location. This is a petrosal vein here which is embedded in the tumor capsule that we preserve. The facial nerve, we preserve the Aica, and we preserve even this superior petrosal vein. So we have shifted back to the medial and the lower part of the tumor here. Coagulation has to be minimal and it has to be away so that you should not damage the adventitia of the Aica here. So we are going on with the decompression, with the sharp dissection. As I told, around any vessel we have to use sharp dissection rather than blunt dissection, and we have to use the bipolar with great care not to damage the adventitia of the tumor and coagulate the vessels. So once that is done, I am taking out thin part of the capsule which was adherent tumor using this sharp dissection and sharp cutting using the micro scissors, and this is the upper part of the tumor, and I am dissecting from the petrosal vein, and the petrosal vein has to be preserved wherever it is possible, otherwise we will have great consequences of venous infarct. So this is the last part of the tumor near the lower pole, near the Aica. So you can see here that is the Aica there. You can see the vertebral artery. There are many perforators arising from the vertebral artery and even the Aica. And this is where I am dissecting. You can see it is quite difficult to take out the tumor at this location. At any moment, I might cut any of the vertebral artery perforators and even the Aica and damage it during while coagulation also. So it is completely embedded, difficult to dissect. And I have to preserve this because this is quite dominant, a large Aica which will supply the cranial nuclei in the brainstem, and if I damage this, the patient will have deficits, and even the preservation of the facial nerve will not make any sense because patient might end up having the nuclear infarcts and deficits as per that. You can see this is completely embedded in the tumor capsule, and I'm gradually taking out. So that's the last part of the tumor. You can see beautifully the whole Aica is preserved here, and you can see the origin of the vertebral artery as we saw in the pre-op MRI. So that is the Aica here. So near the Aica we expected to see the sixth cranial nerve actually here. So this is Aica that is completely preserved, it is pulsating, and that is a part of the Aica near the cerebellum, and it is pulsating, and that is a petrosal vein you can see, and this is the last part of the tumor, that is a choroid plexus. And once choroid plexus comes in a view, you should be aware that you are around the origin of the lower cranial nerves. So choroid plexus in the foramen of Leska marks the origin, and it guides that you are around the cranial nerves, lower cranial nerves. So we have to be cautious to preserve and should not damage the local nerves at this location because they originate tangentially and you cannot see them properly. So we continue to decompress the ventral, the floor part of the tumor here. So those are the local nerves, and that is the capsule. And still you can see that is a Aica that is originating from the basilar artery. In view we are able to see the vertebral artery, and that is where the tumor capsule is adherent to the Aica there. And once I'm sure that there's no nerve and artery, I am coagulating and cutting this part, and through the transparent arachnoid you can see the basilar artery down there. So we'll be encountering sixth nerve that we have to keep in mind, and because that is a thin stretch now, and we should not inadvertently damage it. You can see that is the junction of the basilar artery. In this particular, this is never seen, because you can see both the vertebral arteries on one side, and the Aica was in that, and that is a vertebral artery joining together to form the basilar artery, and the Aica is arising from the basilar artery. So you can see all the cranial nerves free from the tumor capsule, and this is a tumor capsule which is quite away, but still some part of the tumor is embedding the Aica, and I'm going to take it out now. So this is a bigger step that we achieved in this particular case to preserve the Aica. So those are the branches which are supplying the brainstem. You can see from the Aica there, they are the perforators. So I'm separating them using a sharp dissection with great caution not to damage them. So as I told, we have to use the bipolar at minimum and minimum settings and for the minimum time, so that we not inadvertently damage the vessels and the nerves in this complex tumor, in this complex location in the CP angle. So this is a part of the tumor that is being cut away from the Aica that I have preserved. It is pulsating very well, and I'm keeping a patty underneath and taking out the rest of the tumor capsule and the tumor part also. So this is Aica which is being preserved, and this is some small part of the tumor that we coagulated and we cut. And after that we are turning towards the IAM part, that is the internal acoustic meatus part. I coagulated this part. As I told, this is a part of the tumor where we encounter the eighth cranial nerve. So in this particular case we could not see, neither preserve the hearing in this particular case. You can see here that is the internal acoustic meatus part of the tumor, and I am taking out using a curate, and usually I drill it and I use a bone CUSA to open this part of the tumor here. Using neuromonitoring, I am mapping the nerve, and this is, you can see, using a CUSA, bone CUSA, I have taken out the superior and the ventral, the superior part and the posterior part of the tumor here. Intracoustic meatus, you can see there's a large part of the tumor in the internal acoustic meatus. So gradually the whole tumor is being exposed using this CUSA. Then using this ring curate and CUSA, I have taken out the tumor. You can see picture in picture. So that is what is the location. The lower side is usually the eighth cranial nerve, and the upper and the ventral side is the facial nerve. So this is what you can see here, the Bill's crest and everything. This is a large part of the tumor near the IAM. So that is a part of the tumor that I am taking at, and we are cautious to see and preserve the sixth nerve in this particular location that is expected to come in view. And that is what is expected from neurosurgeon, that you have to anticipate and have a proper 3D anatomical vision. That is a sixth nerve coming in a view. It is quite thin, fragile and adherent. If I would have cut the capsule there, I would have damaged the sixth nerve. So we have to anticipate, we have to have that proper 3D orientation of the surgical anatomy that is distorted by the tumor, and still you expect in relation to these arteries and the nerves and the location that you have seen in the MRI, and you have formed your surgical 3D orientation while you spend around 6 to 8 hours of your surgical time. You get a 3D orientation that where what is expected. So this is how we expected the sixth nerve, and we have preserved here. And this is a part of the tumor that we completely took out. It is wrongly named. It is fourth cranial nerve and superficial artery in the superior part, and that they are the rootlets of the fifth cranial nerve. That is, this is the petrosal vein. You can see. That is, the facial nerve is coming in a view. That is a facial nerve. Using neuromonitoring, we are able to feel the facial nerve here. So then gradually I take out the capsule which is near the facial nerve, and we practice sharp dissection here. No pulling, no blood dissection in this location. That is the facial nerve, you can see going into the interlocustomic meatus. So that is the interlocustomic meatus of the nerve. You can even monitor the facial nerve in this interlocustomic meatus part. So this is the last part of the tumor that I am decompressing in the interlocustomic meatus using CUSA and ring curate. So once again I am confirming that the tumor is out in this location in the interlocustomic meatus, and in picture we saw that the whole tumor is out. And this is the papery thin part of the tumor that was adherent, capsule was adherent to the brainstem, and absolutely there was no plane. So in this particular case, it was not possible. Even we saw in the scan that there was an edema there, so we could not breach this part. These are local nerves. I am using a neuromonitoring and preserving the local nerves there. They are completely preserved. This is both the vertebral arteries, and that is Aica originating up away from the vestibular artery, and this is a sixth nerve, and this is a complete resected cavity. You can see here that the sixth nerve is preserved, local nerve preserved, that is Aica, and the whole tumor is out from the interlocustomic meatus. You can see in the picture. So that is a completely dissected and preserved Aica, which was badly embedded in the tumor capsule. So the whole tumor is completely excised except this part of the hardly a millimeter of part of the tumor that is adherent, and absolutely there was no plane, and underneath of which was the facial nerve crossing. So that is the Aica there. This is a petrosal vein, and they are the trigeminal nerve roots there. So this is a tumor bed here. There is a sixth nerve. There is a facial nerve you can see. So the facial nerve is preserved, the Aica is preserved, the petrosal is preserved, and the tumor is out. So the IAM part of the tumor is removed. We saw cranial nerve from 4th, 5th, 6th, 7th, and lower cranial nerves. So once that is done, hemostasis is achieved, and this is a post-op patient after 1.5 months actually. And this is absolutely no facial this thing, and we close the dura and replace the bone flap back. And this is the post-op imaging. You can see the post-op MRI shows that the tumor is completely taken out. A small bit of tumor, a white spot you can see, that is a small residue that we saw. It was having a poor plane with the brainstem. So these are the other cases of local nerves. And as I told, the whole surgery for vestibular schwannoma is to the facial nerve rather than to the tumor. So we have to preserve the facial nerve in all the cases of vestibular schwannoma and remove the tumor completely, so that the quality of life of the patient will be better. And with the time and with the progress in the techniques, neuromonitoring and everything, the surgical skills should evolve, and we all should attempt to remove the whole tumor and preserve the cranial nerves, rather than keeping a capsule with the facial nerve in the setting of preserving the facial nerve function, leaving back the tumor and submitting the patient for a gamma knife. Many of them they can't afford in our region, and in this case we saw that these are 3 cases I showed here, and the whole cranial nerve is removed, and tumor is removed, and cranial nerves are preserved. There is a facial nerve there. In few cases we have preserved even the vestibulocochlear nerve and hearing the patients. In this particular case, you can see that whole of the tumor is removed, and the cranial nerves and the vertebral artery, basilar artery, and all these cranial nerves from the 4th down to the 5th are completely excavated by removing this tumor and preserving all the cranial nerves and even the surrounding blood vessels from the vertebral system. So the goal of vestibular schwannoma treatment should be total removal in one stage and preservation of neurological function, as they determine a patient's quality of life. This goal can be achieved safely and successfully using the Retrosigmoid approach that we have done here, and using neuromonitoring. Thank you for watching this video.